So really happy to have Karen Ng presenting to us today. So she's joining us. I'm assuming that's not from the hospital where she works, but from her own home,
Yes.
where probably most of us are. So Karen is a pharmacist working with the Surrey Memorial Hospital since January of 2019. She's been working there developing the Opioid Stewardship program there. So I know Jackie has been in contact with you. Jackie is our pharmacist here in Regina that works with the Opioid Stewardship program here. So Jackie was able to twist Karen's arm and get her to do a presentation to talk a little bit about their Fraser Health Opioid Stewardship program. So I will let her take over. And again, if you have any questions, please feel free to enter them into the chat, and we will all connect again once Karen's done.
Perfect. Okay, great. Thanks everyone for inviting me to share our experiences. It's really exciting to connect with everyone else who's trying to start up a new program. We were in the same boat when I started last year. So my name is Karen. I also work with Ksenia, who is an opioid stewardship pharmacist at another Fraser Health hospital. And our manager is Mike Legal, and he helps us with our overall opioid stewardship program. Just make sure. Okay. All right, so I know you all understand opioid stewardship, but when we were first starting, we certainly had to explain this. It's quite a new concept, and it's certainly modeled after the successful antimicrobial stewardship programs. Our goal is to optimize use, monitor, and evaluate opioids, and also support human health. So it shows that there's multiple components in this program, that there's both the clinical components and there's also the components where we do need to spend the time to analyze, collect data, and to evaluate how we're using opioids so that we can better optimize how we're doing. What we want to do in our opioid stewardship program is to prevent opioid use disorders. There's a lot of resources that are put into addiction treatment for people who already have established opioid use disorders. But what we want to focus on is more on the prevention. So we looked at study from 2017 where they asked patients with established opioid use disorders how this came to be through some open-ended, structured interview questions. And they basically said that there's 5 main pathways of how they developed an opioid use disorder. The first pathway is from prescription opioids for inadequately controlled chronic physical pain. So they're started on opioids, the dose gets escalated higher and higher, they develop tolerance, and then escalates. Pathway 2 is when they really only use it for a short period. Say they have a little injury and they're prescribed a short course of opioids, but it puts them towards this path of continued opioid use where they can't stop. Pathway 3 is when they actually already have an established substance use, so they know that they have risk factors, but then they're introduced to opioids, and these are patients who know that with the first dose they knew this was just another substance. And pathway 4 is patients who aren't actually using it for pain. And I've seen some of these patients now who say, I'm actually using it more for depression, it really lifts my mood, and so I'm trying to use it that way. And pathway 5 is the one that is most thought of when we think about how it's used, and that's more for recreational purposes. So that's not the pathway we're focusing on, but you can see there's 3 main pathways where prescription opioids for pain can be intervened on, and then 4 pathways where really, if we can modify how we prescribe opioid prescribing, we can help to prevent opioid use disorders. So those are the 4 pathways that when we set out our program, we wanted to try to influence. When we try to look at the risk of opioid dependence and misuse, there's quite a bit of evidence out there, and it ranges, but in this 2018 systematic review and meta-analysis, it shows us in a review of 6,164 articles that the risk is probably about 4.7%. So if we think of all the patients in hospital who are on opioids, and it's roughly about 50% when we looked at our hospital, 50% of patients at any one time on opioids. But we really need to zero in on those 1 out of every 21 patients who are possibly at a higher risk. So if the number needed to harm is 1 in 21, how do we pick out those highest risk patients and not get bogged down by all of those other patients who are also on opioids, because that is primarily the risk that we're looking at. And we always explain that it's not just about decreasing use, same as antimicrobial stewardship. It's not just about decreasing antimicrobial use. It's about balancing the risk and the benefits. We know that there's benefits in acute pain, palliative care, cancer-related pain, and so people often feel scared using opioids in acute pain, and that's where we know that there are benefits. But what we want to target is where we have some evidence that there is no benefit. So there is evidence that in chronic pain, opioids are no better than not using opioids, and in fact, there's greater harm. And there's RCT data on this now. Whereas to really highlight the risk, and not just about the short-term risk of constipation and drowsiness, which is what we often counsel about, but rather to talk about the long-term risk of opioid use. So if we're trying to use opioids for chronic pain, there's the risk of dependence, addiction, and overdose, constipation, but also falls, fractures, injuries. So for the elderly who have pain, if we start using opioids, we also need to explain that, you're at a higher risk of osteoporosis. And so if you do have a fall, which you're at a higher risk for, you're at a higher risk of breaking your bones as well, and immunological and hormonal dysfunction. So these are the types of side effects that we haven't in the past focused on as much. And often when I explain these to patients, they really have no idea and have never heard of this before. So what we really want to achieve is balance. If we look into the history of opioid use, we've swung one way to another from, in the past where acetylmorphine was just produced post-war, we had a period of widespread use. And then we also went into a period of complete opiophobia, where we weren't even using opioids for cancer-related pain, and really patients were only told to use it when they were within weeks of dying. So we've really swung between widespread use and opiophobia, and now we've swung back to widespread use from our past 20, 30 years of all the advertising, false beliefs of opioids. And we don't want to swing towards opiophobia again, because that's what we're at risk of. And that's what opioid stewardship is about trying to reach that balance so that we apply some evidence, figure out where it's beneficial and where it's harmful, and use rational prescribing, risk stratification, consider really close monitoring so that we don't leave patients behind and swing too far on either side of that pendulum, because we're certainly at risk of that, and we see that in practice. So that's our target. When we set out to build our opioid stewardship program, we looked for some available guidelines. The US is quite a bit ahead of us on this, so they actually have some more sort of steps in how to build an opioid stewardship program. So the first of this is the National Quality Partners Playbook. They were very instrumental in developing the antimicrobial stewardship guidelines and the playbook there. So they have a similar playbook for opioid stewardship. This was released out March 2018. And what they've outlined is 7 fundamental actions. So if we are to develop an opioid stewardship program, we need these 7 components. We need leadership commitment, changing the culture overall in an institution. We need organizational policies, so it's not just in one place at one time, but overall, we need overall organizational policies. We need the clinical knowledge, expertise, practice, family and caregiver education and engagement, and then a about tracking, monitoring, reporting, and accountability, and that we really need to collaborate with the community because it's not just about institutional use. So the National Quality Partners Playbook, you do need to pay for this in order to get the copy of their playbook. But what is free that you can download is the Society of Hospital Medicine guide, and they have quite a detailed guide of steps of how to assess your institution, how to build your opioid stewardship program. And they outline these steps. 7 steps that you need to form an interdisciplinary team, have institutional support, assess your facility and how we're managing pain management, because we know that every institution is different, whether you have acute pain service or not. Assess your best practices in hospital for pain management, and then choose metrics and develop a data collection plan, because every institution, depending on your systems that you're using, may have different metrics that are possible. Deploy interventions and monitor impact. So that speaks to clinical involvement, and then improve transitions of care. So again, that's talking about maybe collaboration with the community again, so that as they're discharged out of hospital, that there is appropriate transition. Also, what was helpful to us was the Joint Commission. They actually, since last year in January, they have now released standards. And this is a group that has mandated for all hospitals to have antimicrobial stewardship programs in the US, but they have now mandated for all of institutions to have these components, which are that we have to identify pain assessment and pain management as an organizational priority, that we have to actively involve medical staff in leadership roles, conduct performance improvement activities, and collect and analyze data. So it doesn't quite speak to a full opioid stewardship program, but it does help us to understand the components that are at least starting there, so that we need to prioritize it and look at how we're prescribing opioids and not just leave it be, and that we're working together to try to improve things this way. They did also release an article that provides more of a framework on how to start up an opioid stewardship program. And really in this article, they've highlighted a very successful program in the States. And what they've said is that we really need strong executive sponsorship. And we felt the same from the very beginning, that we really needed executive sponsorship from the hospital and also from the health authority. Because one important thing is that this program can't be housed in one clinical department. So although, for example, in our program, it's led by a pharmacist and a manager is a pharmacist. But we can't think of this as a pharmacy program. It really needs to be thought of as an institutional program. It can't be housed in any one clinical department. Because we need cross-disciplinary collaboration and inclusion. We know that every department in the hospital has some sort of hand in opioid use, so we can't be thinking of this as one department. So that was really key for us as we were beginning our program and how we advertised ourselves. This article was just released last month about the current state of opioid stewardship. It's actually not that current, because really when the survey was distributed, it was in March 2018. So I feel like since then, with the Joint Commission having mandated some of the opioid stewardship issues, that these numbers are probably much higher, hopefully. But in March 2018, just to give you an idea, give all of us an idea, in the United States, 23% of the 133 hospitals that they surveyed had an opioid stewardship program or were in the stages of planning an opioid stewardship program. So it wasn't a lot back then, about a quarter, but again, I think the number is probably higher at this point. 14% have reported a prospective screening process. So this is important to us because we think with antimicrobial stewardship programs, the real backbone of that is audit and feedback. So are we using similar techniques in prospectively screening for high-risk patients? Now, their screening question that they ask doesn't necessarily mean an audit and feedback type process. It just means screening. So, for example, screening for naloxone use, screening for high opioid use, but less in terms of details of how they reacted to that. 45% of hospitals report restrictions of PCAs. So we looked at this, for example, in BC and felt that patient-controlled analgesia was not an issue in our province. It didn't seem to be overused, and in fact, our anesthesiologist on our committee felt maybe it was, if anything, underused in our province, but I think it really depends on your practices. So again, it speaks to assessing your own hospital, your own institution, and what the practices are like. 90% of those hospitals reported a pain management service. In our hospital, for example, we only have an acute pain service, but we don't have any a chronic pain management service. So, or another pain management service that isn't just interventional. So 90% is high, and of course that would influence how we would practice opioid stewardship there. And then 67% reported that palliative care service was providing pain management. So again, speaks to your own institution. So when I started, some of the programs that I really looked at to help me give really good examples of how successful opioid stewardship programs were set up. I looked at Brigham and Women's Hospital, Penn Medicine, Kentucky Hospital. I contacted some of their leaders as well, just to make sure that we were sort of on the same page. And this was especially important in how I collected metrics, because there's not a lot of published evidence on this yet. So I wanted to see if we were doing roughly the same thing. The University of Michigan Open Network has been very useful in some of the work that they've already put out. What I found was that in the US, it's often combined with an opioid use disorder treatment program. So the two programs are often grouped together, but we distinctly wanted to separate these because we had the resources already for opioid use disorder treatment, but we didn't have the prevention piece. So we wanted to separate that. And they looked at, physician leaders and pharmacist leaders, and either one of those seems to be successful in the model. The US is well integrated with their electronic medical record, which unfortunately we are not. So they're able to do so much more in terms of alerts, easy access to data that I'm very jealous of, but we don't have. But what I couldn't find was description of audit and feedback work. Again, what's considered backbone in antimicrobial stewardship programs isn't really described in opioid stewardship programs as much. So I'll just give you some background about Fraser Health Authority. Fraser Health is one of 5 regional health authorities in British Columbia. It does stretch a large geographic area, as you can see from the map that I've posted there. It encompasses 12 acute care hospitals, ranging from Burnaby in the west and going to White Rock to Hope. The hospital that I work in is Surrey Memorial Hospital, and that's the largest of 3 regional hospitals in Fraser Health. And that was why we chose to focus on both Surrey Memorial and also Royal Columbian, which is another regional hospital in Fraser Health. And to give you some idea, we have an acute pain service. Like I said, nothing that is non-interventional after the acute pain stage. We have addiction medicine service and we have palliative care service, and neither of those provide chronic pain service. We do have a chronic pain service outpatient clinics, and in certain cases we're able to consult them in hospital, but they are out of hospital, so there is nothing in hospital for chronic pain patients. We were funded in 2018. In early 2018, we basically were able to write a proposal for prevention of opioid stewardship programs, because there's a lot of, like I said, resources put into treatment of opioid use disorders, but not so much in prevention. So we had one pharmacy director who wrote a business plan for prevention piece, and we were funded for 2 pharmacists only for all of Fraser Health. So that was why we decided to put the 2 pharmacists in the 2 regional hospitals. So in Royal Columbian Hospital, a pharmacist was hired in February 2018, and she shortly went on mat leave, which is why the clinical work there started later in June 2019. And I was hired in January 2019 for Surrey Memorial, and I started the actual clinical work in March. So I spent about a month training, just getting used to the wards in Surrey, and February just doing some background work, and March was when I actually started the clinical work. Our objectives, I'm sure, are similar to yours, about preventing adverse outcomes, promoting optimal prescribing. We were asked a lot about whether we were influencing community outcomes. So mostly we say that we provide immediate local impact within the institution, but we believe that there's a lot of patients where we then, because of that involvement, then have impact in the community in the long term. And as I said before, we've explicitly excluded any patients who have an established opioid use disorder, because those patients would fall under addictions, and they would be managed by the addictions team. We exclude palliative management, again, because there's already that team, and also if a patient already has acute pain service involved, then I would not be involved until they have signed off, just so that we don't have too many cooks in the kitchen. Our initiatives try to align with what's been stated in some of the guidance. So we've tried to form strategic collaborations, and we wanted to do a similar program to audit and feedback, but we didn't want to call it audit because we felt that with opioids it was already highly stigmatized. So instead we call it prospective patient case review and feedback program. Opioids and benzodiazepines were a large target for us. So we set out to target this combination, as I see that a lot of existing opioid stewardship programs are also targeting combination opioids and benzodiazepines. We wanted to work on organizational policies and procedures. So that's where, although I'm working only in Surrey Memorial, a lot of my work in policies and procedures are for Fraser Health. And so we think that there's that wider reach there. Promoting evidence-based practice, enhancing family and patient caregiver engagement, also supporting a little bit of research within our program so that we contribute to this developing area, supporting community collaboration and monitoring and evaluating use. So this is a sort of a draft, because it's not really an established regional pain service yet, because some of these are not yet in place. What we would imagine is that it would reach from tier 1 up to tier 5 based on how severe the patient is. So tier 1 is the well population, and tier 2 is where opioid stewardship would fit in, because it's about secondary prevention, about screening, evaluating patients before they develop worse pain or worse risk factors. And then there's also, goes up to primary care networks, and then community hubs is also where I participate in with hub pain programs. And then the highest tier is where we have the chronic pain programs. And we hope that by having these different tiers that we help more patients to access care for pain. When we started, we put together a logic model to try to think of our activities, outputs, and also the outcomes. So you can see our list of metrics that we tried to come up with that were feasible for us based on our system. And we also, one thing that was very important was to have that executive sponsorship. So although we were funded, we weren't initially, we were funded by Fraser Health, but we needed our individual institution sponsorship and commitment as well. So we spent quite a bit of time just trying to reach them, meet with our hospital directors, clinical leaders, and invite them into working with us together. So we looked at who the stakeholders would be. So of course there's all the prescribers of opioids, which reach many different departments, clinical pharmacists, patient care coordinators, the pain clinic, the emergency network in terms of reaching out to opioid use disorders, addictions team, and again, the services in the community. So what we formed was the Opioid Stewardship Advisory Committee. So this is not a group of funded individuals. So they're more for advisory support, and we meet once a month. So we started this in June of last year, and we have representatives from the various departments. So you can see, there's the three of us in opioid stewardship, but the rest of the individuals are all of the stakeholders as well. So we have an anesthesiologist, a hospitalist, a general surgeon, an orthopedic surgeon, emergency department physicians. We have clinical leaders. We have an executive director, as well as pain nurse, addictions medicine. So we try to put a group together of individuals who are very interested in optimizing opioid use. And like I said, we meet once a month to try to guide the development of opioid stewardship, and also for a chance for all of us to work together. We think of our program as having three main components. So there's the clinical involvement, which is kind of like the audit and feedback program, which we're calling prospective case review and feedback. And then there's also the two other components, which is practice guidance and surveillance, where we create, review PPOs, evaluate opioid use, promote the program, promote the principles, and then there's also education and research. The third box of activities. Another thing that we did when we first started to understand the hospital and the institution is to do a point prevalence program. So this was very helpful for me because Surrey Memorial is 650 funded beds, but we reached up to 700 and something beds. So I needed to see where to focus, and a point prevalence survey is the best way to do that. So I did that in February, and that was part of the background work that I did. And I basically looked at all of the patients in hospital who were on opioids. And this shows the percentage of patients in each of the wards or the services who are on opioids. So not surprisingly, 100% of orthopedic patients, majority of surgery patients, and then you can see down the line. But what was very important in prioritizing the work is this pie chart to see where I should try to focus the actual audit and feedback type of work for. So you can see if I cover medicine, and then the red is orthopedics, the green is general surgery, that gives me 63% of reach. If I could cover emergency, that reaches 3/4 of the patients in the hospital. So really, I don't need to screen the entire hospital for opioid use because that would be not feasible. But if I could screen the majority, that already helps me to reach most of the patients on opioids. And so in some of the other data that I got from this point prevalence was it showed me that most patients had acute pain or they had acute on chronic pain. So it's not just about chronic pain management. Shows like some of the risk factors that I would be looking at for patients. So about 8.8%, for example, have an alcohol use disorder, and these patients would be considered higher risk for developing an opioid use disorder. And it also shows that we're not doing well in optimizing non-opioid pain management. So, for example, acetaminophen was optimized only less than 40% of the time, and then NSAIDs are highly stigmatized now, and so you can see it's optimized basically scheduled dosing, and only 6.9% of patients who are on opioids. So this shows again some of the targets that I would have. And prescribing practices, this was helpful in establishing a baseline. So I won't go through details of those, but it does help in just figuring out what the baseline of opioid use is like. So basically, with that data, I was able to decide where to focus. We eventually decided not to focus on the emergency department just because the turnover was too high for the case reviews to be feasible. We looked at where to prioritize, what I would be looking at in terms of the focus. So we now do prospective case review and feedback routinely on those 3 areas. So that's medicine, orthopedic surgery, and general surgery. And then I also provide phone follow-up for select high-risk patients. So I either receive, either find patients through screening or I accept referrals. Oops. And so patients are identified either of those 2 methods. I then complete my case review and feedback, which included a variety of interventions. I communicate these recommendations back, and then that's generally it. Usually it's about a one-time intervention rather than like a pain service where you would continue to follow the patient. So I only follow patients only selectively. So most of the time we consider it more of a one point in time. Excuse me. Of course, as they're monitoring, if there's additional help that they need, they can always refer a patient back to us. In our advertising, we also gave some of the flags for patient factors and medication factors for them to flag for us and to show appropriate patients for referral. In terms of promotion, we started off small. So it was primarily through word of mouth that as I started with more and more wards that there was more word of mouth. And then we sent out emails and newsletters to alert everyone of the service. So we sent out specific emails also to hospice as well as hospital-wide emails. We advertised in newsletters, we emailed patient care coordinators, and of course through meetings with stakeholders. This is our activity since March, so this goes until the end of March, so basically covers 13 months. You can see I've had 837 patients that I've intervened on. Acceptance rate is 91%, and I've had 205 referrals. It starts off fairly low, so you can see last year when I started, it started off low, and now I'm at about 24 referrals a month. And it shows the breakdown of who they come from. So right now it's about half and half physicians and pharmacists who refer patients to me. The top interventions are optimizing non-opioid analgesia, stopping unnecessary PRN opioids, providing education, changing or optimizing an oral route, and also tapering opioids. And we've also given out 55 kits just in Surrey alone. Non-clinical activities are, that we have joined a team called the Quality Assurance Team, and this is where we review all of the incoming changes for pre-printed orders. As well, we have also produced our own tools. So some of the examples would be the post-operative discharge opioid guidance tool and inpatient tapering guidance tool. For practice guidance, we've also tried to convince surgeons to stop using long-acting opioids for acute post-op pain by imposing an SBAR. We've collaborated with Med Reconciliation team to look at documentation because that was a huge issue for us, that duplicate prescription records were not kept, and then some knowledge and research, knowledge dissemination and research that we've done. So here's the example of our discharge opioid prescribing document. We're still in the process of, we have approvals from each of our institutions, but we're now getting health authority approvals. So we're presenting later this month again to the Fraser Health Surgery Department. This is the SBAR that we created that they have accepted and are using to now change all the PPOs to take off long-acting opioids. These are some examples of the pre-printed orders that we now look at, all pre-printed orders for opioid orders, and these are some of the changes that we would be recommending. So in wrapping up, I can speak about challenges that a lot of the problems with opioid prescribing is embedded within PPOs. So until we can correct or change some of these PPOs, a lot of these are still practices that are often embedded. We have poor record keeping. So like I said, discharge prescriptions is one area where there's just very poor record keeping of opioid prescriptions. There's certainly gaps in transition. So when patients are discharged, there isn't always a good a transition of care with their opioid management unless we are focusing on that one patient and we've had a referral, but we're missing the majority of patients. We need improved electronic medical records for continuity because once I've written a note, the next time the patient is readmitted, sometimes that note can be missed. And there's still lots of fear and stigma involved. And lastly, just comparing this with antimicrobial stewardship, which we're all familiar with, some of the differences are that there's no apparent right or wrong. Like when we're looking at just their opioid prescriptions, it's not immediately apparent. We spend much more time in screening. We often need to discuss with the patients as well. It's not just a simple, intervention just by looking at the prescriptions. And sometimes these interviews can take a very long time, especially if they're complex pain patients. The chart notes can be very long, so sometimes you can spend a whole day on just maybe 2 or 3 patients, and that's taken up all your time. I found that physicians are generally appreciative of opioid stewardship help because not everyone has that time to spend on looking at chronic pain. So it's nice to have that service to look at this. And patients can also disagree with recommendations. So it's not just about prescriber acceptance, it's also patient acceptance, and that every patient in every scenario is so unique. So it's quite different from antimicrobial stewardship in that way. So yeah, I'd love to hear your comments and work with you on this and any discussions for the group.
Thanks, Karen. That was awesome. I certainly have lots of questions, but I just want to open it up to the group. And, if there's anyone who has any questions, we didn't receive anything in the chat, so I'll give maybe a 10-second count here. If anyone has any questions, you can type them in or unmute your mic and ask away. And if not, I will definitely pose some questions. Okay, no takers. So I a lot of that. I mean, just it's awesome that there is another group going through the same stuff that we've been kind of going through in the last year or so as well with our opioid stewardship program, and trying to find what do we do, where do we work, what does that work look like, who are the stakeholders, all those kinds of things. One of the things that's at the top of my mind right now is that as we're looking, we're operating off of a grant right now, and so we're looking to see how we get this embedded within the Saskatchewan Health Authority in the coming years. So I was wondering if you have any other tips, pointers, or just can comment more about that process that you guys went through to actually have the Fraser Health Authority embed this within their funding structure.
Yeah, we got our funding more from emergency operations. So I guess it was still mostly from addictions treatment that we were able to get a little bit of their money and therefore fund the 2 pharmacists, and that's all that we are funded for. But I think what's been really helpful is setting up regular meetings with them and showing some of our data as we go, and just showing examples of stories, because that's really helpful, just showing, these are patients that we've helped, giving them very specific examples, showing some of the specific work. So for example, this is what we would provide a patient in terms of a tapering guideline. This is what we would provide for the physicians so that they don't need to look at opioid prescribing. We can look at, we have a very hospitalist-based program in Surrey. So with hospitalists changing over every week, there's no continuity, and we're there to help provide that continuity for those challenging, complex patients. And then showing them, for example, the discharge letter that we would provide the GP, so that it shows the transition. of care. And then, of course, what we would hope to eventually show is also, I guess, not just approval rates, because I feel like acceptance rates are just always very, you can manipulate it in so many different ways. If you feel like it won't be accepted, just don't make the that recommendation, for example. But what we would hope is to eventually collect some of the feedback from prescribers to show that this is a service that is considered useful, and also feedback from patients. So especially, for example, patients that we do discharge phone calls for, are they actually continuing on with safe opioid use practices? Is it actually helping with their pain? Is there better satisfaction with pain? So yeah, I think keeping them up to date and connecting with them regularly has been helpful.
Hi, Karen. It's Bob Parker, the manager for stewardship and clinical appropriateness. I think you've touched on a really important part. So my understanding is that you are primarily like acute care based. Is that correct? And then like we started off more in our community base, and I think we're kind of coming to that same point at the same time, perhaps around that transition from acute care into community, or community, or from acute care back into community, or moving from acute pain into chronic pain. And I think that's one of the things that we're going to see this year come up for us as we establish, like Jason was talking about, that dedicated funding. The model of that transition is really, really important. And like, have you found that you are, like, you've got your representation on like on your advisory committee? What I've been trying to establish is like a very, not really that, I guess, we're taking on the responsibility for chronic pain, but those partners come in. So like mental health and addiction knows what part they own, acute care knows what they own, and let's say surgical services knows what part they own with interventional medicine, like those kind of things. And then community within primary health understands what their part. Like, are you trying to do a similar, or do you essentially take on in your opioid stewardship program? And I guess, yeah, like that would be my question. Do you take on all that responsibility within your program, or do you try to have that linkage where they're accepting the responsibility for their part of this?
I mean, we're mostly trying to connect so that we work together. So, for example, on the advisory committee, we have one, she used to be a pain nurse, but now she is trying to build the framework for Fraser Health's pain program. So working with her in designing a transitional pain clinic is one of, I guess, the ways that we're trying to work towards this. I mean, it's quite impossible for everyone to take on additional responsibilities beyond what they already have. So, for example, acute pain service is so busy with their work that although we can talk about what would be ideal, they can't actually give dedicated time to work on this until there's dedicated funding. So I feel like a lot of this has been in planning stages, in trying to get some initial funding for us to build the transitional pain models and transitional pain clinics, to look at what that would look like, where that would be situated, how we would communicate with each other, how to identify patients. So we haven't taken on additional responsibilities outside of acute pain. It's just more that it provides that venue for discussions between all of us, and just recognizing that we're all working towards the same thing. And so there's just all these connections that we can make in establishing what an ideal model would look like.
Okay, thank you. That's helpful. And then I guess, and you may have covered this, I may have missed it, and but like operationally, what portfolio do you fall under? Like as a pharmacist, are you within pharmacy, or are you in a separate portfolio?
Yeah, we're funded out of the Emergency Operations Committee still so far. So it's the Emergency Operations Fund. And that money flows into pharmacy to hire me. but it isn't a pharmacy fund. It's still the emergency operations fund. Yeah, does that answer that too?
I think so. Operationally, you are out of pharmacy department.
Yeah, so I'm hired out of pharmacy because they give the funding to pharmacy to hire me. But yeah.
Okay. Right. Yeah. I have some, like I hold certain positions within stewardship and clinical appropriateness. I hold some positions that are in opioid stewardship specific, and then I have positions that are like part of, say, primary health community that I fund from the funding that I get. That funding then goes to different areas, and that's part of the piece around promoting that stewardship aspect of everybody has to own their piece and know their piece. Like you build that hub and spoke model, and then how do we establish that? I'd be interested in having further conversation with you because, like I said, and I kind of go back to that part around that transition piece, and I think that's really important. We're starting to see our patients in community transition into the acute care system. And especially right now with COVID, this is a really vulnerable population that we have to be keenly aware of, and depending on what their what their care plan is, that we make that care plan accommodated in the acute care system. So thank you very much. I'm mindful of everybody's time. I've probably taken up. I'd like anybody else, if they've got questions for Karen, this is a great opportunity for some collaboration here.
It's just cutting out for me. I didn't hear the.
So I think maybe we'll stop there. I think as Bob was saying, there is certainly I think you are a wealth of information, and I'm sure that at least speaking on behalf of our team in Regina, we would love to continue to connect with you and pick your brain and know more about the type of work that you guys are doing and what's worked and what hasn't, those kinds of things. So if you're open to that, and certainly I think if anyone has any questions that they would like to follow up on, please feel free to email them and to us. And if you're okay, we can pass them along to you, Karen, if there are any questions for you through that process.
Thanks very much, Karen.
Yes, please. I'm definitely happy to continue the conversation so we work together and face our challenges together.
Great. Okay, well, thank you very, very much for your talk today. And thank you everyone for joining us. And we will see you all again. I believe next month we are planning to have another speaker from BC who will be talking about the Do Bugs Need Drugs program. So